Thank you so much for joining us today. We will be recording this, but we will stop the recording at the end when we have some question and answers, or time for question and answers. And so please just note that. So if we want to ask questions at the end, know that those will not be recorded. So welcome to our webinar today. The title of our webinar is Opioid Overdoses, Risk Factors, Signs, and Saving Lives. And I'm going to turn it over to my colleague Laura Poblombi in just a few minutes, but we have a few little things we wanted to do before we get started. So one of the things, if you feel like you want to share in the chat where you're from, that would be great. And then if you feel comfortable, please share how opioid overdoses have affected your community, and not asking anyone to share personal stories, but share what you're comfortable sharing. And so thank you for everyone in the chat for doing that. We'd like to know a little bit about why you're participating in the webinar today. So if you could, a poll just popped up in front of you. And so you should see that you have three options: personal reasons, professional reasons, or both personal and professional reasons. I see some folks answering. Welcome everyone. If you just joined, we're just taking a poll on why you are participating, getting a little data on why you're participating and the purpose of you attending today. And if you just joined and you want to feel comfortable sharing in the chat, please do your name and where you're from, and maybe how the opioid overdoses have affected your own community. Okay, I see that we have, most people have answered our chat or our poll, excuse me. And so it's we find this often, right, that people attend both for professional reasons as well as personal reasons. So thank you for sharing that with us today. Okay, I'd like to give a shout out to Rick Meyer, who is helping to support this webinar today and really helping with all of the details and making sure that everything runs smoothly with registration all the way to just getting us up and running today. So we so appreciate your help, Rick, and are really grateful for you to be here today. Okay, next I'm going to turn it over to my colleague, Laura Poblombi, who will introduce herself. But thank you, Laura, for joining us today. And we look forward to learning from you and with you.
Thank you. Well, thanks so much for having me. It's really my honor and privilege to do this training. I'm a pharmacist by training, and I work at the University of Minnesota College of Pharmacy on the Duluth campus. And I'm very fortunate to get to do a lot of naloxone trainings with my community partners. Marcia Gurno at Rural AIDS Action Network and Dr. Beth Bilden from Essentia Health. So I want to acknowledge them as we do this presentation together, and the community members who have taught us along the way and helped us to figure out what exactly people need to know. So we're going to talk today about what some factors are that might increase a person's risk of opioid overdose. We're going to talk about signs and symptoms of opioid toxicity. So opioid toxicity is when you've had too much opioid. And people experience opioid toxicity before they reach the point of overdose. We're going to look at the different pros and cons of the different naloxone formulations. So naloxone is the generic name for Narcan. So I'll probably refer to the drug as naloxone along the way, but I might talk about the brand name Narcan. So if I use both of those terms, it's the same thing. We're going to talk about resources to access naloxone as well as legal considerations in the state of Minnesota. So before we get started, it's really important to acknowledge, first of all, many of us that are in this webinar have been affected by opioid use very personally, or maybe substance use. And so we really want to acknowledge that this could be triggering if you've been very personally impacted by the opioid crisis, and maybe a loved one that you know and love has been struggling with opioid use, and maybe even worse, you've lost a loved one to opioid overdose. So if this applies to you, I just want you to know that my heart is with you. all of us, our hearts are with you, and that's why we do these trainings, because we want to prevent the loss of life. These are preventable deaths because we have a life-saving drug available. So it's really important that everybody carry this drug. If you could possibly run across someone who could be experiencing overdose, which is pretty much all of us, overdose rates continue to rise. We know that's been the case, especially since COVID. So it's really important. We're going to talk about naloxone, but all of us should be carrying it. And so I'm going to talk about different ways that you can access naloxone and carry it as well. So before we get started, we want to acknowledge that all of us have our own beliefs when it comes to substance use and opioid use. And we really need to practice some self-awareness about what those beliefs are. Our personal beliefs can actually turn into biases if we're not careful. So it's important to take a step back and think about that. What our experiences do we have with people that use substances, and how could those negatively be impacting us? And really, we all have biases towards many different things. So that's a good exercise to kind of think about. We also need to remember that most people want and value the same things in life: a family, a home, control over one's life, social acceptance, all sorts of things that we all value. But because of their substance use disorder, these things kind of disappear as a priority. They become dependent on a drug. And so we need to take a step back and remember that they didn't aspire to this life of using substances, that they have a life before the need for intervention that we need to remember, and remember them as people first. That's a really important message when it comes to this training, is remembering somebody as a person first, not just as somebody who uses substances. So the language that we use when we talk about substance use disorder is really important. So about 80% of people with a substance use disorder will never access treatment. And that number is so high because of stigma. In no other health condition do we see 80% of people not getting help. It's just a really sad disparity. And we know that stigma is the number one reason for that. And there's things that we can all do to address stigma and make this better. And really, like I said, it comes down to talking about a person as a person first, not a druggie, not an addict, a person with an opioid use disorder. We should never use terms like that. And I'm a pharmacist. I've worked in a pharmacy. I've heard these terms. So if you're a healthcare provider, yes, this applies to us. So addict, junkie, user, those are all inappropriate. We can talk about somebody who struggles with opioid use disorder as a person with an opioid use disorder. There's also terms that we could use: neonatal abstinence syndrome or neonatal opioid withdrawal instead of addicted babies. Medications for addiction treatment or medications for opioid use disorder are appropriate. Those are also known as MAT, so medication assisted treatment. But really, we're trying to normalize that every disease state requires medications. So it shouldn't just be medication-assisted treatment for opioid use disorder. It's medications to treat opioid use disorder. And then also when it comes to urine drug tests, some of you might, half of us here are here for professional reasons. Maybe you encounter people who take drug tests. So instead of saying clean or dirty, we can say positive or negative for a drug screen. And then dirty syringes, instead of saying dirty syringes, we can say used syringes or sterile. So getting away from the clean and dirty language is really helpful when it comes to reducing stigma. Also, instead of talking about overdose, we can also refer to it as a breathing emergency. That's something that we're all working on, because we've always talked about this as opioid overdose. So before we get started, we want to talk about what actually are opioids, because a lot of people take opioids and they don't even know it, including some of my family. So we have pharmaceutical opioids. So those are things that get prescribed to you or perhaps your pet. So morphine, hydrocodone, oxycodone, it could be fentanyl patches. We also have some illegal opioids. So these are non-pharmaceuticals that are purchased on the street. So that includes fentanyl, which you may have heard is laced in many substances of use. And a lot of times people are getting fentanyl and unfortunately having an overdose and passing away, and they don't even know that they're getting it. So one thing that's impacting our youth, especially right now, and you may have seen the DEA warning about this, is that there's a lot of fake pills on the street. So you can purchase pill presses online, and what drug dealers do is they purchase the pill presses and they make pills that look like pharmaceuticals. So they are stamped and they look like the same color, the same stamp, and they sell them on the street, and youth especially are being impacted by this because those pills very, very often have fentanyl. And so we have a youth that might think that they're getting an anxiety pill or a sleeping pill or an opioid, and what they're getting is fentanyl. And unfortunately, that's been a really, really unfortunate, deadly trend in our country. So those are illegal or non-pharmaceutical opioids. And that's our biggest threat right now. It's not the pharmaceuticals that people are being prescribed. It's the non-pharmaceuticals that are on the street, how fentanyl is laced in our drug supply, including methamphetamine and cocaine, and also in those pills. There's also heroin, which is considered an opioid, and a whole bunch of street names here that I'm not going to list, but there's different names, and they change all the time because drug dealers want to get around law enforcement knowing what those terms are. So the signs and symptoms of opioid use or misuse. So this is somebody who is taking opioids, maybe prescribed opioids too much, or maybe even as prescribed. And maybe it's just too much of a dose for them, or somebody that might be misusing them. So you might notice impaired memory or a hard time paying attention. Their pupils might be constricted. That means tiny. That's not the best sign right now because fentanyl actually doesn't cause that. They might be scratching their skin. They may have a runny nose, nausea, sleepiness, and nodding off is a very good sign. Slurred speech, stupor, which means not as conscious, and then slowed breathing. And there's a few of these that we're going to pay very close attention to because those are the signs that we worry about somebody actually having an overdose. But these are the signs of use and misuse here. So these are the signs and symptoms of overdose. So if you encounter somebody who is not responding, this is very important. If you can wake them up, it's not an opioid overdose. If you can wake them up and they're conscious and they're just breathing slowly, that is not an indication for naloxone. What we're looking for are those top two. So they are not responding and they have slow breathing or no breathing. This is a breathing emergency. And this is what causes death when somebody has too much opioids and experiences a breathing emergency. So they're either not breathing or slower than every 5 seconds. They may be making gurgling, choking, or snoring sounds. This isn't the snoring sound that you've probably heard people that are, sawing logs. Like we all know a snorer, right? That's a regular snoring noise. This is not like that. This is irregular. It sounds like they're choking. Blue lips and nails is another potential sign. That means somebody's not getting enough oxygen. So that would be something that you'd look for. Cold or clammy skin, and then tiny pupils is another one. But like I said, fentanyl, the synthetic fentanyl doesn't always cause that. The top two that you're looking for are the slow breathing or no breathing and somebody who's not responding. If you see these, call 911 before you do anything else and report a potential drug overdose. You won't be charged with drug possession if you have drugs on you. This is a really important thing for us to share. If maybe some of you might be doing train the trainer someday or talking about naloxone in your workplace, it's called our Good Samaritan laws, and we're going to talk a little bit more about that. I'm going to take a quick pause for questions. I've talked for a bit here. Any questions on anything I've covered so far?
There's no questions in the chat right now, but if anyone wants to even unmute and ask a question, you can do that, or you can put them in the chat and we'll monitor that.
Okay, I'm going to keep going, but feel free
There's
to.
one question, Laura.
Oh, okay.
Peg asked in the chat, what if a warrant is out for someone who calls?
That is a tricky question, and I am not sure how to answer that. I will show you where the legal, we're going to go through the legislation. I have never been asked that question before. So I think if there's a warrant out, it might be different than the traditional Good Samaritan law where if it's just, like a bunch of people using substances together, they're not supposed to ask questions. However, I would not want to say, yes, they're definitely safe and then be wrong about telling you that. So that I think is tricky and probably also depends on who's responding. I hate to say that, but we will go over the laws and again, if you want to email me after, I'll give you my email address and I can definitely check on that for you. So good question. So what is an opioid overdose? Opioid overdose occurs when an opioid alone or with other drugs overwhelms the body's ability to handle it. Now, we've done lots of research studies on people that have unfortunately passed away because of an overdose. And very, very often, it's a very high percentage. It's not just an opioid in the person's system. It's very rare that somebody has an opioid overdose and it's just an opioid. More often than not, it's an opioid and another substance, such as alcohol, because alcohol is also a depressant. So that's a very bad combination, unfortunately, when you mix painkillers or even opioids off the street with alcohol. Um, Also benzodiazepines. So those are drugs used for anxiety, like they end with PAM. So lorazepam or Ativan, those sorts of drugs that are pretty common, actually. Again, those are also drugs that cause sedation. And so when you combine them with an opioid, it's a really bad combination. Additional drugs would be like Ambien, or other drugs that people take for sleep. So those, those additive effects can be really deadly. As pharmacists, we should be advising people on that. But sometimes people, when they come through the pharmacy, they're in a hurry. They don't necessarily want to talk to the pharmacist. So it is really important for all of us to be aware. So what actually leads to an overdose death? It's a breathing emergency. So the respiratory failure is what causes somebody to pass away, and that results in basically lack of oxygen in the blood. So when somebody's not breathing, and we're going to talk about this. So opioids, when somebody takes an opioid, it reduces your body's desire to breathe. Basically, your body's not recognizing that it's low on oxygen, and the breathing rate decreases. It's sending the signal to the brain. Because of that, you're not getting enough oxygen through your lungs, and then your organs like your heart and your brain start to fail because they desperately need oxygen. This leads to decreased consciousness, respiratory depression, and death. And so surviving an opioid overdose is really about breathing and oxygen. If you are trained in rescue breathing and don't have naloxone, that is the very best thing you can do for somebody until help arrives. So we're going to talk a little bit about that. So how does naloxone work? So this is really important because naloxone is actually a quite safe drug, and a lot of times people are nervous about using a drug, rightfully so. We have a healthy respect for drugs, but really, as far as drugs go, it's one of the safest ones out there, and that's why it's available over the counter. You can purchase naloxone from a pharmacy just by going in there and asking for it. They can even run it through your insurance in the state of Minnesota. And it really just depends on what your copay is. And we can answer more questions about that if people are curious. But right now, we're going to talk about how naloxone works. So naloxone is a high affinity mu receptor antagonist. Well, what does that actually mean? That means that it looks a lot like the opioid in the body. So when somebody takes an opioid, whether it be orally or maybe they're injecting an opioid or inhaling it, it ends up in the bloodstream. So the opioid circulates in the bloodstream and it goes into the brain and it binds to these mu receptors in the brain. So I always show my hand as an example. So this is the receptor. Here's the opioid. It binds in there kind of like a magnet. It sticks, right? When the opioid binds like that, that's when it sends that message to the brain to stop breathing or slow breathing. And that's what can kill somebody. When you get enough opioids, it just overwhelms the body's mu receptors and it shuts off your breathing. How naloxone works is it actually binds in that same spot. So when naloxone comes into the body, it basically kicks out the opioid and binds in its place, and it sticks a little better. So it's kind of like a stronger magnet, right? So it displaces that opioid, and when the naloxone binds in its place, it doesn't send that same signal to the brain to stop breathing or slow breathing, and so the person's desire to breathe comes back. So that's why we might need to give them, depending on how many opioids they've had, we might need to give them a lot of naloxone, multiple doses. So the naloxone comes along and binds in the receptor, kicks off the opioid, and the opioid's still circulating. And the naloxone gets into the bloodstream in the kind of the same way. So naloxone can be injected. So if it's injected, it goes directly in the bloodstream. It can also be given intranasally, which I'm going to talk about. When it's given in the nose intranasally, it actually gets absorbed through the little blood vessels. So it does not need to be inhaled. We get that question a lot. Like, if somebody's not breathing, how do they actually get that inhaled naloxone? Not inhaled, absorbed into the little blood vessels in your nose. One thing that's really important to remember, though, is the naloxone binds kicks off the opioid, but unfortunately the opioid is still there in the bloodstream circulating around. We don't have a drug that destroys the opioid yet. So we might give somebody naloxone, bring them back to life. They look like they're fine, but the opioid is still there. And unfortunately, the naloxone only lasts between 30 minutes and an hour in the body, and the opioids last far longer. So it's really, really important that somebody get medical care. That's why we have to dial 911. At the very, very least, we have people that are not going to dial 911. At the very, very least, that person should not be left alone, because what can happen is they can have a subsequent overdose. So they get the naloxone, naloxone comes off the they get the naloxone, the opioid comes off the receptor, naloxone binds in its place. They come back to life. They look great. We think they're doing fine. Unfortunately, when the naloxone wears off, they can have another overdose. And so again, we cannot leave them alone. We should dial 911. They need to see medical care because we're seeing people need many, many doses of naloxone. I've done these trainings all over, and I remember in one place, I believe it was Grand Rapids, they needed 9 different administrations of naloxone to keep the person alive until they actually got to the emergency room. This was the ambulance and had to do that. So it's really important to not just, so that's why we keep the kits, we keep those doses together in the kit. We don't want to separate them because we very likely will need the second dose, and we may need more than that. So especially if somebody lives in a rural area, for that reason, we recommend you take several kits if you're worried, because you might need to give somebody more than just the 2 doses as you're waiting for EMS to arrive. Because I don't know about you, I've lived in a rural area before where it would take a very long time for EMS to arrive. So it's important to make sure we can keep somebody alive until EMS arrives. So what's neat about naloxone is it doesn't have any other effect in the body. So we don't have to worry about causing somebody harm by giving them naloxone. It only does this one thing. There's many other drugs out there that do a lot of stuff. So like, epinephrine, right? We don't want to give somebody an EpiPen if they're not having an anaphylactic reaction, because we could actually cause some harm. With naloxone, we cannot cause harm. The only thing that it does is bind in that receptor. So that's really important for people. People need to know that when they're giving naloxone, because we might be nervous and scared. We've done trainings and people have told us later, yeah, I wasn't sure if they needed it, but I gave it to them anyway because I knew it wasn't going to harm them, and I'm glad I did. So there's no dependence or tolerance, and there's no effect in the absence of opioids. So again, it's as harmless of a drug as possible. That's why it's available over the counter. And there's different dosage forms available on the market. So the first one is the intranasal branded Narcan nasal spray. So that's probably the one that most people have heard of. There's also the injectable generic. So this is naloxone injectable. We are grant funded. So a lot of times when we're grant funded, we buy as much of the injectable as possible because it's a lot more affordable. Especially our partners in harm reduction, they dispense a lot of the generic injectable because it's much, much cheaper. There's also the injectable generic given intranasally, and that one's given with the fine mist. I'm going to take another pause before I get into these specifically. Was there anything about the mechanism of action, how naloxone works, that people have a question on?
There's no questions in the chat right now, but if you
Okay.
want to pop them in there, you can, or we'll just monitor that.
Okay, sounds good. So we're going to talk a little bit about these different dosage forms now. So the first one we have here is the Narcan nasal spray. So this is the branded dosage form, and it comes in the little box as pictured here, and in each box are these 2 little devices, and again, we keep them together. We don't want to separate them for that reason I mentioned. We might need to give somebody more than 1 dose. So these are approved for adults and children of all ages because they are very, very easy to use. They're also more expensive than the pre-filled syringe formulation. So if you were to purchase these at the pharmacy and pay the full cash price, they're over $100. But this is the one that the pharmacies dispense. So if you go in and ask for this and they bill it through your insurance, you would get whatever your copay is. So for some people, the copay might be $10, could be $20, $40, or $0, depending on what kind of insurance you have. So how this works, and there's discounted pricing available to community partners. So if you are a part of a community group, you can get this for $70 a kit instead of $110. So the little device looks like this. There's a plunger and you push it in and it goes in the nose. I'm going to show you here. So what you're going to look for, so again, we're looking for those two major signs that I talked about before. So somebody who is non-responsive, which means we can't wake them up, and their breathing is slow or they're not breathing at all. So those are the two things. A non-responsive person who's not breathing well, or they're making those choking sounds and it's slow breathing. So you're going to spray the contents of one device into one nostril, but you just push the plunger in, and then you're going to repeat with the second device into the other nostril after 2 to 3 minutes if there's minimal or no response. Now remember, this gets absorbed into those tiny little blood vessels. If you see somebody and they have mucus in their nose, like many of us do during allergy season in the winter in Minnesota, if you have a cloth where you can wipe away some of that mucus, that will help for this to be absorbed better into their system. So if you notice that, feel free to wipe that away. And again, here's a little picture. So you see the plungers down, then we push the plunger up when it's in the person's nose, and it's pretty easy. The other dosage form that we do a lot of education on is the intramuscular injection. And like I mentioned, this is the one that we do a lot of trainings with because it is a lot less expensive. This is a dosage form that our partners in harm reduction most often dispense in the community. It comes in little vials like the one pictured. And this is what it looks like, this little vial here. I have my blurred background, which isn't helping us, but you can see what the vial looks like in the picture. And they also come in this light-proof bag. Really important to keep it in the light-proof bag so it doesn't degrade. So again, can be vials or ampules. Each kit has either 2 or 3 vials, depending on where you get it from. This is a little trickier to use because it does involve injection. So it has a syringe, which if you're anything like me, I am the type of person that's a little nervous in an emergency. So if it were me in an emergency, I'd be shaking. So, but like I said, even though it's more difficult to use, it's really a lot less expensive, so we can save a lot more lives with it. So how this works is, again, the same thing. We're looking for lack of breathing in an unresponsive person. We're going to draw all the medication from the vial and inject 1 milliliter into the thigh or upper arm or shoulder muscle. So here's the vial. You're going to flip off this orange lid first. That's a plastic lid. The needle will not make it through that. So you got to flip it off, and then there's going to be like a rubber stopper underneath. And then you take your syringe. So the syringe comes in a packet like this. You pull it off. You're going to take the lid off very carefully because it's a needle. And then what I would do is set this down on a firm surface. And after you've pushed off this little lid, you're going to take this, and then again, I'm going to take the lid off. You're going to take this, turn this down, and then you're going to flip it around and pull all of the liquid out of the vial. That's going to be your full 1 milliliter. And then you basically just give this to somebody like a flu shot. A lot of people get nervous because a lot of us aren't trained in how to use needles and syringes, but it's actually anybody can do it. It's just tricky if you're nervous and it's an emergency. So most important thing is to pull all of it out. You don't need to worry about air in the syringe. You're going to give it in the upper arm or thigh, and I'm going to show you a picture of where that is. And again, repeat in 2 to 3 minutes of minimal response or no response. One important thing, if you are giving somebody this injection, it's really important. We don't just give it and then just kind of set down this needle, right? Like, we don't want to do that. We don't want to have needles just sitting around. So you're going to take the needle and scoop the lid back on it and put that lid back on. And then we're going to put it in a sharps container or like a plastic pop bottle. We don't want to just leave needles laying around. So here's the sites where you administer. You can see the arm site. It looks like the same area where you get your flu shot. And the thigh, basically, that's not the best picture. It's basically if you were sitting between your knee and your hip, your thigh muscles there kind of on the top is where you would want to inject into the muscle. So we do have some special safety considerations. Thanks to COVID, we do things just a little differently. So we definitely recommend personal protective equipment such as gloves and face protection. You want to position the person's head facing away from you as you're giving this, because if the person vomits or wakes up and coughs, they'd be coughing away from you. You're still going to do the naloxone according to the instructions for use. And then if you're trained, we do recommend you use those other life support measures, such as rescue breathing or CPR. with a face shield. As the person regains consciousness, you're going to stand up and step back 6 feet, just like the 6 feet we see in many other locations. And really the first step of this, which we talked about, is to call 911, right? That should probably be number one. But these are the steps you're going to take if you are the person giving naloxone. When you take off your PPE, avoid touching your eyes, nose, and mouth. Wash your hands with soap and water for at least 20 seconds. And then if you do end up, sometimes when people wake up, they might vomit. That can happen. So if that were to happen, you'd want to change your clothing. As far as adverse effects for naloxone, if somebody's not taking opioids, we're not going to expect any adverse effects. Like I said, naloxone only does that one thing in the body, just sits on that one receptor. So if they're not taking opioid, it's not going to do anything at all. There could be product-specific reactions. So that could be dryness in the nose if you give them the nasal version, or an injection site reaction if you give them the injectable. The alternative, if they are experiencing an opioid overdose, is death. So the nasal dryness and injection site reaction are pretty minor compared to that. This can elicit precipitated withdrawal. So that means somebody goes into immediate withdrawal from an opioid. This is not a pleasant state at all. Somebody might feel awful and they can just be really upset. We're going to talk about that later too. Pulmonary edema can be one potential side effect, but we're not sure if that's actually from the overdose or the naloxone, but we still, just to be thorough, report that. And then if you are giving rescue breaths and oxygen, that might limit the development of the pulmonary edema. As far as storage and disposal of naloxone, you want to store it in its original package at room temperature. Like I mentioned, we want to keep it away from light. That's why it comes in the light-proof bag, because it will last a lot longer. We want to keep it in a safe place away from children and pets, not because we're worried about them being harmed by it, but because children and pets can get into things and ruin them. I have children and pets. I feel like I can say that confidently. They get into stuff. So keep it where you keep your first aid kit, where people know where it is, but away from kids, pets. If you're in the office space, keep it with the other first aid kit. Make sure people know where it is, because it doesn't help if you have it and nobody knows where it's at. And like we mentioned before, we have to store both doses together because we might need to use both of them. You do want to check the expiration date on the label. If you have expired naloxone and you encounter somebody who is experiencing an overdose, we would still recommend you use the expired naloxone. It lasts far beyond its expiration date with very little loss of effectiveness, and it doesn't turn into any kind of harmful byproduct. They've done studies and found even after it's been frozen and thawed and sat around for, I want to say, up to 30 years, it still works somewhat. So I'm not recommending you use naloxone that's that old. However, if you have expired naloxone and you can save somebody's life, just do it. If you do notice that your naloxone is expired, then you'd want to bring it into one of our harm reduction agencies across the state. We have Rural AIDS Action Network, which serves much of the state. We have Steve Rumler Hope Network in the Twin Cities metro area. We have Harm Reduction Sisters. So any of those agencies will take your expired naloxone and give you a fresh dose. And again, drug disposal, if you've used that syringe, put it in a plastic pop bottle or a Sharps container. And then when EMS arrives, you're going to want to let them know how much naloxone you gave somebody, because that's important information for them to know if this person's already had 4 doses or if they've had, just one. That they need to know that. Some special population considerations, and again, just to be thorough, if somebody's pregnant, this does cross the placenta and can precipitate withdrawal in the fetus. Again, the alternative, however, is likely death. So withdrawal is unpleasant, but death is far worse. In neonates, it can cause seizures if given to neonates born of moms with opioid dependency. As far as lactation, we're not sure if it's excreted in breast milk, although it is very poorly absorbed orally, so we're not worried about an infant getting much naloxone. And then in the geriatric population, as we get older, all of us, our kidneys and our liver just don't clear drugs as well. So as is the case with every other drug in the geriatric population, it's going to stick around in the system a little longer. You don't need to adjust the dose. So I'm going to take a quick pause again. Anything that I've covered, any questions before we talk about myths?
There's no questions in the chat right now, but if someone wants to unmute and ask a question or pop it in the chat, please do. I put RAN, Rural AIDS Action Network and Harm Reduction Sisters websites in the chat as well for folks if they want to check those out.
Thank you. Okay, so we're going to talk a little bit about the myths and misconceptions with naloxone. And we didn't used to present on this, but we were getting the same questions all the time after these presentations. So now we just address it in the actual presentation. So the first myth is that naloxone is a controlled substance. And I think this stems from the fact that naloxone works in the same way as an opioid. So people assume that it's also a controlled substance, but it's not. Like I mentioned, it is pretty harmless. It just works on the mu opioid receptor. If somebody gets it and they are not having an opioid overdose, you're not going to cause them harm. So it is available over the counter. There's also the myth that somebody's going to automatically be aggressive after you give them naloxone. This is a myth. There are people that most definitely are aggressive after administration. Most often, though, this is the case. I shouldn't say most often because I don't know that we know if it's most often, but often this happens because people that are okay, so many people do what's called speedball. So that's when you combine an upper and a downer. So that would be like using cocaine and heroin or methamphetamine and heroin. It's very common to combine an upper and a downer. Or it could be somebody taking cocaine that's laced with fentanyl or methamphetamine laced with fentanyl. So the fentanyl and the heroin are the downers. Those are opioids. And then the cocaine and the methamphetamine are the uppers. So if you're taking an upper and a downer at the same time, and you experience an overdose, so maybe you're taking cocaine, which is an upper, and it's laced with fentanyl, which is a downer. They have an overdose. You take away the downer. Now, so you give them naloxone, you take away the effect of the downer. Now you're seeing the effect of unmasked methamphetamine. So we know that this is definitely something that happens in a lot of overdose reversals, is that now all of a sudden we're seeing somebody who's got unmasked methamphetamine. It's also when somebody goes into precipitated withdrawal, it's a unfortunate, like uncomfortable state. So they're not going to be happy because it's very unpleasant. Are they going to automatically be aggressive? No. A lot of times people wake up completely confused, not knowing what happened. And so that definitely can happen. And so that's why we recommend just step away. There's also the myth of somebody being harmed related to administration. Hopefully we address that. I think it's healthy to have a fear of how drugs work, but this is one that is very safe. There's also the myth, especially among our healthcare provider population, that giving somebody naloxone enables them and continues their opioid misuse. So pharmacists in particular, I'm a pharmacist and I've done studies with pharmacists, and a lot of times this group of people is hesitant to give out naloxone because they feel like they are enabling and they are contributing to opioid misuse. And they've done research and studies on this, and we have learned that that is not the case. Somebody's going to use opioids whether they have naloxone or not. If we give them naloxone, we give them the possibility of saving their life and getting them into treatment. If we refuse it, we are refusing life-saving care. We would never do this for somebody with asthma. That's what is really frustrating. If somebody has asthma and needs their rescue inhaler, would we say, no, we're not going to give you your rescue inhaler because you exposed yourself to paint fumes, which is one of your triggers, and now you have an asthma attack. So I'm not going to give you your asthma inhaler because you did this to yourself. No, we would never do that, right? And we have other life-saving drugs like glucose for somebody who's having a diabetic emergency. So we shouldn't do that with opioids and with naloxone, but unfortunately there's a lot of stigma and bias within our healthcare provider community that we need to address. There's also the fear of significant liability. And again, as you learn about how naloxone works, you will see that that actually is not something that we should be concerned about because of how harmless this drug is. A few more clarifications. Naloxone saves lives. We know naloxone that we are getting out in the community is saving many, many lives. Unfortunately, we don't get a lot of good data back from the community. We know that what we're dispensing in the community is working. People's lives are being saved, but we don't necessarily know how many. That's really tricky to figure out. So naloxone is an effective opioid antagonist and works for all opioids if administered early enough. And it's a very, very valuable harm reduction tool. It keeps people alive until they're ready to seek treatment. We also have we're going to talk a little bit about some of our legislation here. So we do have in Minnesota some, it's called our Good Samaritan laws. So this is there's different branches. So non-healthcare professionals acting in good faith, may possess or administer an opiate antagonist that is prescribed, dispensed, or distributed by licensed healthcare professionals. So if you are just a lay person, like the majority of people out there, and you do this training, which you're doing right now, and you have naloxone, you can give it to somebody and be covered by this branch of the law. We also have a branch for healthcare professionals. So this is a healthcare professional who does these things as a part of their job. Again, they are also protected from liability. What's ironic to me is that we have these laws so that people feel safe in giving somebody naloxone, but like I mentioned, it's such a safe drug. So we have the laws so people feel covered, but really there's not a lot of harm that can happen, and there's a lot of good in saving somebody's life. But regardless, we have these. We also have the Opioid Specific Good Samaritan Law. So this is immunity from prosecution. This is the one for the person that asked about the if there's an outstanding warrant for somebody. So a person who seeks medical assistance for another person who is experiencing a drug-related overdose may not be charged or prosecuted for the possession, sharing, or use of a controlled substance or possession of drug paraphernalia. This does not say anything about this person being picked up for a warrant, however, so that's where I feel like they can't be prosecuted for having drugs or drug paraphernalia, but it doesn't say anything about if they have an outstanding warrant. So I would not say that that person would be definitely granted immunity. So again, a quick review here. So in the event of an overdose or breathing emergency, first, stay calm, call 911. You'll go through the steps in giving naloxone that we talked about. When they wake up, you're going to explain what happened because they might not know what happened to them. Let them know that the sick feeling that they have, if they're in precipitated withdrawal, will go away when the naloxone wears off, which is in about 30 minutes. Encourage them to go with EMS, who hopefully has arrived by the time that you give them naloxone and they're waking up, and then give the EMS empty naloxone containers. If you are in this situation, it's really important for you to debrief and get support. This is kind of a traumatic thing to save somebody's life and be in the midst of an opioid emergency. So it's really important to get support from either, if this is in the line of work, from your workplace, from a counselor. There are resources out there. So again, just a quick review, how to respond to the emergency. We talked about looking for the things that might indicate somebody's having an opioid overdose, not responding, slower, not breathing, and some of those other signs, and then follow those steps. So try to wake them up. Are they unresponsive? So stimulate them. And we can do a sternum rub. So we make a little fist and rub somebody's sternum. That's really uncomfortable. So if they're going to wake up, they're going to wake up from that because it is not comfortable. If they're not waking up, call 911 right away. Then open their airway. If you are comfortable giving them breaths, that is really helpful because, again, this is a breathing emergency. We have breathing masks in some of our naloxone kits, and that's something that we're ordering too. So you're going to want to give them breaths and evaluate them. If they're still not breathing, you're going to give them the naloxone, so the nasal spray through the nose or inject it. You're going to try to keep giving them one breath every 5 seconds. And then evaluate and support. If they're still not responding after 3 to 5 minutes, keep giving them naloxone. So we have a couple naloxone video links here. So basically kind of going through the process. Then I have a couple harm reduction resources here. So these are some resources that reach a lot of greater Minnesota. So Rural AIDS Action Network and Harm Reduction Sisters, and their websites are here and their locations. Harm Reduction Sisters is mobile, however, so they go to a lot of different places far away from Duluth. In the Twin Cities metro area, we also have Steve Rumler Hope Network, and they also have a broad network throughout the state. So if Duluth, Virginia, Hibbing, and if this isn't a part of your geography, you can also try Steve Rumler Hope Network because they also have that network across the state. You're going to have my contact information. You can also email me. And I also do these trainings for community members all across the state. So if this is something that you are watching and maybe on behalf of your organization and you'd like a training for your organization, my name is Laura and you're going to see my contact information shortly. So we can do a training for you. If you're able to access naloxone and just want to know how to use it. And we do have these videos online as well. So we have the Department of Health Opioid Dashboard, which is an excellent resource if you want to kind of track how the state of Minnesota is doing. Spoiler alert, I'm just going to share this. We actually have one of the worst sets of disparities in our state. we lead the nation, unfortunately, in disparities for American Indian people. And I think we're about number 6 for people that are African American when it comes to comparing BIPOC communities to Caucasian communities. So we really have a lot of work to do. The opioid dashboard is a place that you can go and track some of these disparities and see how your community is being affected. We also have the SAMHSA National Helpline, which is a wonderful resource for getting help for mental health or substance use. If you're working with somebody and not quite sure what to do, we have poison control, another really great resource in our state. Again, if you're at an opioid emergency, definitely call 911. But if it's something where you're wondering how to help somebody, or you run across a drug and you're not quite sure what it is, they're used to answering those questions. So here's my contact information. We can take some questions now, and then we can also turn off the recording in case there's questions you want to ask that aren't recorded.